Hi, I'm Dr. Paul Kuo from Stanford University. I'm delighted to be with Dr. Tatyana Kushner from Cornell University. And we're going to take a few minutes to talk about the changing landscape of viral hepatitis and what has been changing. And Tatyana, welcome. We really appreciate your insights here. Why don't you just briefly tell us where you think we stand right now with regards to the control of hepatitis B and C? Are we making progress?
I think we are making progress, and the two disease states are obviously in very different stages of the process. And obviously, the goal is to work towards viral hepatitis elimination by 2030. And in the US, we're making significant efforts to accomplish that. With hepatitis C, it's clear we have a great cure. We have very high SVR rates. We have great medications. But now it's about getting those medications to all the people that need them and really expanding the populations that we're treating. My personal interest is in bringing hepatitis C medication and treatment to pregnant people, which are commonly excluded from treatment recommendations, for example. With hepatitis B, I think really our focus is working towards functional cure. We have medications that control viral load, but we don't have really medications that cure hepatitis B. And at the session we were at just together, I think it was very exciting to hear that finally we're seeing some promising candidates that are approaching phase 3 of drug development. So I'm very optimistic about both, but I think there's still a lot of work to do.
Yes, I agree with you. And we have the tools. So much of this is now, I think, for hepatitis C implementation.
Yes.
Right?
Exactly.
Because, for decades, they came to see Dr. Kushner in clinic to treat their hepatitis C. But now to really eliminate this, we will really need to bring the treatments to them wherever they are. And the treatments are straightforward enough that can be done.
Right, exactly. It's finding those difficult to reach populations because we've treated everyone who we can treat. Now we really need to be creative about getting the treatments to those that are more difficult to reach. And then speaking about updates in therapies, like recent advances, we were just at a session together where Ira Jacobson spoke about hepatitis B functional cure. So can you update us on where we are with these new therapies? What's in the pipeline? What do you see as promising for achieving functional cure?
Sure. So we can suppress the virus, as you were saying. So, we have first-line therapies, nucleotide analogs. They suppress the HBV DNA. What they don't do is they don't clear surface antigen levels at high rates. In fact, they're very, very low. And ironically, the therapy that we have now, which is the least popular by far, interferon, which we can give for 48 weeks, actually does have a not insignificant surface antigen clearance rate. The challenge is just getting patients to be willing to tolerate that therapy for a year. It's very, very challenging. And so happily, we're starting to see, as you briefly alluded to, that we now have therapies which are targeting the surface antigen levels and driving them down so that the nucleotide analogs, entecavir and tenofovir, they can make the virus level in the bloodstream go down, but they don't really affect the cccDNA in the hepatocyte. They don't really clear surface antigen. We're just now seeing classes of medicines that are coming into phase 2 and now phase 3 trials where we're able to inhibit the synthesis of the virus, actually prevent synthesis, and then by interfering with the RNA machinery so that we can drive the surface antigen levels down to low and undetectable levels. And as you were just briefly alluding to, bepirovirsen, which is what we call an ASO, antisense oligonucleotide. And what this does is it actually cleaves the messenger RNA. It binds to it and then degrades it. And these antisense oligonucleotides, they have another added feature. They have some innate immune toll-like receptor activity as well. And that also, in combination with reducing the surface antigen levels, actually leads to surface antigen clearance. And when given for 6 months, the surface antigen clearance rates in all comers weren't spectacularly high. They were 10, 11%. But on the other hand, that's better than we get with interferon. And it's our foot in the door, and I think it's our proof of concept that we can do this. And their phase 3 trials are underway. They're going to combine this in the future with other therapies. There's another way to inhibit the RNA. This is silencing RNA. And what I think will be fascinating to see as we reduce the surface antigen levels is that does pharmacologically pushing the surface antigen level down let the innate immune system take over and clear, and then make sure that you maintain a functional cure. These aren't the only classes. We have now therapies that are studying. There's a direct-acting antiviral agent called a capsid inhibitor. There were several that were tested a few years ago. They suppress virus, but don't really seem to affect surface antigen levels until the latest generation. And there are now capsid inhibitors which do seem to reduce surface antigen levels. These are next generation, more potent. These are going to be entering clinical trials as well. And in addition, there are other classes, including immune modulation. There are entry inhibitors. We'll get to hepatitis delta. There are monoclonal antibodies available as well. And I think all of these classes are going to have to be in some way combined to allow us to get to the surface antigen clearance rates that we need. And we will, with regard to thresholds of treatment, if we can get surface antigen clearance rates that remotely match SVR rates in Hep C, then elimination will clearly be better. And speaking of elimination, hepatitis C elimination, which you have devoted your career to, what do you think is working, and where do you think we need more effort directed toward?
Yeah, I mean, clearly what's working is the medications. So the medications are highly effective. We have excellent treatments for hepatitis C. What's not necessarily working as well, or where we should really direct our efforts, as you already mentioned, is being able to reach the populations that are hardest to reach and simplifying treatment even more than what it is now. I mean, we have the 8 to 12 week regimens for hepatitis C. But we still recommend frequent testing at times. Can we simplify this? Can we develop programs that are rapid test and treat programs where you go outside of the health setting into the communities with high-risk populations, do point-of-care testing, which is now FDA approved, and provide treatment right there and then. I think that's really where the field is going, where we have a very seamless, rapid cascade of care that doesn't delay initiation of medications, and at the same time really goes out, as you mentioned, into the community to offer rapid test and treatment initiations to those that need it most.
Yeah, and what I saw was so interesting is now there are some preliminary data with long-acting injections for hepatitis C. I mean, it's early days, right?
Early, yes.
But the concept, don't you think, is reasonable?
I do. I mean, I think in certain populations that really will be the only thing that works. These patient populations, at times, the idea of adhering even to an 8-week treatment course with daily medication, sometimes 3 pills a day, is challenging. I've had a few patients that I've tried 3 times and they're not able to actually complete treatment. So I think in certain populations, the injectables really will be a game changer.
Yeah. And do you think we still should keep trying for a hepatitis C vaccine, or do you think that which has been elusive? Yeah. What do you think the concept it's worth still pursuing?
I think it's an interesting concept. I struggle a little bit with understanding in which specific patient populations it would actually be able to implement it, much less can we even develop this vaccine that's effective. And how do you go about developing a vaccine like this, where in some situations you would infect an individual with hepatitis C and then offer treatment. So I think, there are even ethical aspects of this that are important to recognize. So I'm not sure. What do you think?
Yeah, I think we have to pursue it for just the following reason. If you look in the history of infectious diseases, almost all of the infectious diseases that we've eliminated have benefited from a vaccine. And so I think hepatitis C, therefore, shouldn't be different. But as you said very accurately, it is certainly not the panacea. We've had an effective vaccine since 1985 for Hep B, and we have implementation, and we still have a large pool of people out there. But I think these elimination strategies are going to really lead to sort of all of the above.
Right. For sure. And then just a word about Delta hepatitis. I think also when we speak about viral hepatitis, there really has been increased activity and recognition of Delta hepatitis, including in the U.S. Obviously, we're not an endemic region, but I think we're understanding that we need to be doing more testing and recognizing hepatitis D co-infection and offering treatment. And there are treatments on the horizon that really appear to be very effective. Now, I think one question regarding those treatments are the same as with hepatitis B. How many of them will have sustained virologic response off treatments? So I think we're very excited to see that there are medications moving into phase 3 of study, but what we're seeing is on-treatment responses, and we saw that with interferon as well. But will we see off-treatment sustained virologic response for Delta hepatitis as well?
Yeah, we hope so. I am also hoping that Delta benefits from the efforts in hepatitis B, because if you clear surface antigen in B, Delta becomes an afterthought.
Right.
Right. But I completely agree with you that we need to make progress there, just because that is so much more of an aggressive disease. And as you said, we certainly, when we talk about expanding screening for high risk groups, the guidances hopefully will evolve. But Delta, I screen everybody with B for Delta, despite what you said, which is that it's really a patchy disease in the United States.
That's right. And I very much agree that we should offer everyone with hepatitis B Delta screening at least once. But I think what is lacking in our current literature is actually a demonstration of cost effectiveness. And similar to what we saw with hepatitis C programs and hepatitis B implementation of universal screening and vaccination, I do think cost plays a role, and the prevalence will play a role in determining the cost effectiveness. And we still don't have really an ideal understanding of prevalence.
Yeah, no, it's been one of the most elusive diseases to try to get the prevalence of. But, I screen people once or twice a year. I'm surprised.
Right, exactly. They're not the classic person that you would expect to have Delta co-infection.
Yes, I agree. I agree completely. And so just finally, we've had some recent guidances. There was a WHO guidance on hepatitis B, and then of course the Chinese guidelines. And it was very interesting that the threshold to treat is falling now. And has that mirrored your practice as well, or are you still follow the sort of the classical 2000 and ALT 2 times the upper limit of normal?
I think when I first started right out of fellowship, with Nora Thoreau being one of my mentors, I very strictly followed those guidelines. But in parallel to really the emergence of these new guidelines and more data, I also have been expanding my treatment recommendations. And I agree, the World Health Organization guidance for sure expanded treatment recommendations. And I do think that the World Health Organization guidance, comes from a public health perspective. But at the same time, we also think about the individual perspective. And I think what we mentioned in our session before is that there's still an element of joint decision-making too. The patient is still part of it. And so we have the expanded guidance, but we also still have the conversation with the patient because some patients, for whatever reason, are still very, very hesitant to go on long-term therapy.
Yeah, no, I agree with you completely. But the WHO, it gave everybody, if you will, the permission slip.
Right.
To say this is something, they commissioned their literature reviews. And what was the other thing that was so interesting was many of the treatment recommendations did not include HBV DNA. Mm-hmm. So if you're in resource-constrained areas, surface antigen positive, elevated ALT, you treat,
right,
as an example. And I think from a public health perspective, that's going to be very, very helpful, particularly because low-cost generics now are not so challenging for hepatitis B. And so I think we will continue to expand while the functional cure therapies over the next 5 years are refined.
Right. And the key question is, when do you think we'll have functional cure? I mean, I've always said in my practice with Doug Dietrich's mentorship, just always say 5 to 10 years. And I've kept saying 5 to 10 years. But in your opinion, how far do you think we are?
I think that we will get functionally approved therapies, hopefully in the next few years, albeit it will be our foot in the door. Early days. So like, for instance, we used to have interferon monotherapy for hepatitis C. Not great, but it was available. The bepirovirsen looks very good in patients who have 3,000 surface antigen levels, which we don't really use much in clinical practice. But if a moderate or low surface antigen level, they work. But I think you'll see improved combinations in the future. And again, there are probably other classes. It's going to be a matter of combining, I think, viral inhibition with either a nuke or capsid inhibitor, then also driving the surface antigen level down with some type, probably in many people, of immunomodulation with B, which you seem to need at least some degree of that, at least for now. Although, again, you never know if you get the right combination of potent viral inhibitors, maybe that isn't required.
Right. I mean, as much as we all hope that hepatitis B will reach the hepatitis C success, I do feel, based on what we know now, that it will remain a little bit more complex in terms of need for combination therapy involving immune agents as well as direct-acting antivirals. But maybe we'll find out that that's not needed.
No, I think you're right. Thank you.
Thank you.